Welcome to Nous, the podcast where I delve into the sciences of the mind. I'm your host, Ilan Goodman, and in this episode I meet a controversial mental health professional who thinks that psychiatry is bad for us. Dr. Lucy Johnstone is a clinical psychologist who has worked for many years on the front line of adult mental health services, helping those who may have been diagnosed with conditions like schizophrenia or bipolar disorder or clinical depression. It's a staggering fact that roughly a quarter of British adults have been diagnosed with a psychiatric disorder at some point in their lives. But Dr. Johnstone thinks that these diagnoses are totally wrong, invalid and unhelpful. Giving someone a psychiatric diagnosis, she argues, is the first step drawing them into a system which treats them as if their problems are symptoms of a physical illness. But that, she argues, is wrong. I interviewed Dr. Johnstone at her home in Bristol, where we discussed her wide-ranging critique of psychiatry and her new initiative, the Power, Threat, Meaning Framework, which is the basis for a radically different approach to mental health, which abandons diagnosis altogether and promises to treat individuals as people with problems rather than patients with illnesses. She has said it's the culmination of her life's work. Dr. Lucy Johnstone, welcome to Nous.
Thank you very much.
So, I want to start with a little background. You've said elsewhere that you became a psychologist partly because of painful experiences you went through during childhood and as a young woman. What I wanted to ask was, did your experiences first lead you to feel critical of the psychiatric establishment, or did you develop those insights and ideas later when you were working within it?
Okay, that's a good question. It's true that, like many people who end up working in mental health services, it's kind of not an accident. And my interest, I guess, can be dated back many, many years to when, as you say, I was quite an unhappy child, young adolescent, young woman. And because of the kind of person I was, my way of trying to work my way out of that was to kind of hide myself away in my room and read psychology and psychotherapy books. I didn't do anything exciting like taking drugs or going to parties, I'm afraid. I was the world's most boring adolescent. So, although I didn't know much about psychiatry as such, it always seemed perfectly obvious to me that I was feeling unhappy for reasons. And, I think I was reasonably clear what those reasons were. It was kind of working through the difficulties that was the problem. So I guess I was set up, and certainly the reading I engaged in set me up to have basically a psychological understanding of distress. And I was of the generation that was quite influenced by Lang and some of the so-called anti-psychiatrists. So that was also the kind of literature that was around. So I'm not one of those people who went into mental health services kind of believing it and then thinking, well, this doesn't seem to work very well and I wonder what the problem is and should we be doing things differently. I'm someone who went in from quite a young age, actually, early 20s, very definitely, with a kind of reforming zeal, if you like, in a rather naive and idealistic sense. But that has actually been, it's been a lifelong journey for me in a way, and it certainly started, as you say, right back when I was quite young.
Yes. And so in turning to the psychology, the textbooks and the sort of famous psychology texts when you were a teenager, you were trying to make sense of your own suffering and your own... Yeah.
I was, as we all do. And making sense is a theme of my work as well, the various ways which you can make sense of our suffering. And if you wanted to put it absolutely in essence, then I think what diagnosis does is take sense away, and all of my work and the work of people that I see as friends and allies and colleagues and supporters is in essence about putting that meaning back.
So we've understood your beginning, searching for reasons, trying to understand your own suffering as a young woman, and then you have been a practicing clinical psychologist for many years. Can you just give us a sense of the kind of work you were doing? What is it? What kinds of people and what kinds of suffering were you seeing, and how were you working with those people?
Okay, I mean, I've worked in a number of different settings, but they've all been adult mental health settings. I've always been fascinated by the kind of severe end of the spectrum, the people experiencing things we might call psychosis, or that we used to call manic depression, or all sorts of things like that. Those aren't labels that I'd use. But as far as I'm concerned, the more challenging and complicated the person's difficulties, the more fascinated I am.
Okay.
And the keener I am to get involved. I mean, I've worked with a whole range of difficulties, but my interest has always been in the kind of, extreme forms of distress that from the outside actually seem quite difficult to understand and difficult to help people move on from. And, that's still the case.
So are we talking about people having hallucinations, hearing voices, having quite wild and unusual beliefs, delusions perhaps? Are we talking that sort of thing?
Yeah, we are talking that, yes. I mean, I like the term hearing voices. I like the term unusual beliefs. I don't like the word delusions. I don't like the word hallucinations.
Okay. What's wrong with delusions and hallucinations?
Because it sounds like medical terminology, and actually, how do you define a delusion? We all have delusional beliefs. A lot of mental health workers believe in mental illness categories. As far as I'm concerned, that's a delusional belief. But try and shift it, you'll realise that, as they say, you can't rationalise people out of delusional beliefs. So it seems to be making a kind of judgment about what's normal and what's acceptable belief that I wouldn't necessarily go along with. But certainly people have unusual beliefs and beliefs that may be distressing to them. And, the short way of describing it might be people who are out of touch with consensual reality, people who seem to be, at least to some extent, living in a different world, which may not be a problem except if it becomes very distressing to them or perhaps very disturbing to other people.
Okay, and I mean, I know this is a very big and very difficult question, but just on a kind of simple level, how do you work with these people?
Well, psychologists are generally trained to work at several levels, which I think is as it should be. So some work might be consisting of something that looks like therapy, or you might be meeting someone weekly, or you might be running groups or whatever. One of the areas I've got very involved with and done quite a lot of writing and training in is called psychological formulation. In essence, it means sitting down with someone over a period of weeks or months and co-constructing with them a kind of story, a personal narrative about your distress, what it seems to arise out of, how we both make sense of it. It's like a kind of personal theory or hypothesis, if you like. And on the basis of that evolving narrative or story, or in jargon terms, formulation, you can think of some possible ways forward. If this is the case, perhaps this might help. So formulation, most psychologists use formulation as a basis for their one-to-one work.
So one of the central themes of your critique of psychiatry is an over kind of dependence on a biomedical model.
It's any use of the biomedical model at all in what we call mental health. Yeah, it's the kind of completely false assumption that human suffering of this kind is best understood as a medical illness, and everything depends on that.
In terms of your personal experience of working within the system, what kinds of negative consequences of that did you witness and experience?
Well, I'm afraid I thought that psychiatry, and by that I need to be clear, I don't just mean psychiatrists, I mean the whole system, because many psychiatrists are very psychologically sophisticated and also have critiques of the system. I'm afraid I found that psychiatry was every bit as awful as I expected it to be. And although it looks rather different now than when I first qualified, which was many years ago, I don't think it's fundamentally changed. It's kind of nothing, everything changes, yet nothing changes. We have new jargon terms and new therapies and new teams and new buildings, but the model remains the same. So because it's a fundamentally inappropriate model, I think what you see is people not being helped, people being turned, as I sometimes put it, from people with problems into patients with illnesses.
Okay, so let's unpack that a little bit, because that's really crucial. So turning people with problems into patients with illnesses.
And that process starts, or can be seen as starting, with the application of a psychiatric diagnosis. When somebody tells you this is bipolar disorder or personality disorder or a psychotic breakdown or whatever. And at that point, everything else follows, often fairly automatically, like you get the pills, which may have some use, but actually there's an increasing amount of evidence that they are not only not helpful, but may actually on average, over the long term, increase disability. There's a great deal of evidence to support that.
Yeah, I mean, and that's really shocking. We shouldn't underplay that.
It's absolutely shocking. It's a shocking, shocking fact.
And I think I first encountered that. Robert Whittaker wrote a lot about that. He was a sort of, I think, quite a key figure from my understanding in exposing that. He wrote a book called Anatomy of an Epidemic. And that's where I certainly encountered the idea that antipsychotic medication,
So-called,
yes, I know you're going to object to the term antipsychotic, but medication that we term antipsychotic, even though it might not have any specific targeted effects, actually might just make long-term outcomes worse.
Yeah. I mean, he's done a wonderful job of following up the data. He's a science journalist, yes. And interestingly, he came at this from a completely different angle as a reporter and a science journalist, thinking, why aren't people getting enough access to these wonder drugs? And the more he looked into it, the more he found that these wonder drugs actually seemed on the whole not to be working. And outcomes, and this is quite a well-established fact, in countries which have much less access to modern Western psychiatric so-called medicine, on the whole have better outcomes. Again,
I think for most people that is quite a shocking and quite staggering fact. Where does the sort of evidence for that come from?
Well, for the detail, read Anatomy of an Epidemic, but it's very respectable evidence. It comes from things like World Health Organization surveys. I don't think you'd actually find many people disagreeing with that. But as you say, it's extraordinary that, to take a kind of analogy, if we found that some of our most serious physical health problems, let's say severe arthritis or certain forms of cancer or whatever, typically resolved with very little intervention after 3 or 4 weeks in certain parts of the world, rural areas of the world, far from Western medicine, we'd all be over there thinking, well, what are they doing that we're not? It actually places a huge question mark over everything that we do under the heading of psychiatry.
So let's just return to this idea of medicalising distress. So turning people with problems into patients with illnesses. How does the psychiatric system do that at the moment, in your view?
By giving people a diagnosis. Everything starts from that. So various practical consequences follow, like the medication, like the possible admission, like you take on this identity of mentally ill, like all the rest of it. But consequences follow in terms of the sense you make of your experiences. So you are offered, or usually have, a version of reality imposed on you, because try disagreeing with your diagnosis, you'll find it's not welcome. And it's a version which, for some people, may feel like a relief. And you quite often hear people say, well, I don't have to feel guilty and I don't have to blame myself or others, and this suggests there might be a way forward and someone's going to kind of give me the treatment that will help me out of this. In reality, it very often doesn't turn out like that.
So people do find it a relief, and they do find it welcome to have a diagnosis, because can we sort of give an example to that of perhaps someone, I don't know what terms you find acceptable, depression, you probably don't like the word depression, or?
Depression's, there's a kind of lay meaning and a kind of clinical meaning, isn't there? So we could all be depressed in the sense of miserable and desperate and fed up. Clinical depression is not an entity I believe in. So you're what I would call, and you may be very, very, very miserable, desperate, suicidal, hopeless, despairing. You go along to it might be your GP. You may not get as far as official mental health services. You're told you have clinical depression. Here's the antidepressant. Well, from my perspective, people get what we call depressed for reasons. There are reasons in people's lives, in their relationships, past and present, unless, there are a few kind of known biological causes of depression that need to be ruled out. But aside from that, I don't think I've ever met someone who didn't, when you got to know them, have actually quite good reasons for feeling miserable and depressed.
But you're not suggesting that anyone thinks the opposite, are you? Or are you? I mean, any practicing GP or practicing psychiatrist doesn't think people just spontaneously become depressed because of some sudden shift in brain chemistry that's got nothing to do with their lived experience? Or does anyone actually think that in practice? Or is it more of the way things work, it's sort of is as if they believe that?
Well, they act as though they believe that. And that may be due to all sorts of things like lack of time and so on. The 10-minute consultation, the pill, which may be appropriate for your chest infection.
So it's as much a byproduct of the way things work as a sort of genuine belief, that, because I can't imagine anyone really defending it.
Well, I mean, what you will be told if you kind of have this discussion with most other people is that we have a biopsychosocial model nowadays.
Yes.
This is a myth, this biomedical model. And, it's not a myth because whatever people say in theory, in practice, that's what you very often get.
Okay, so biopsychosocial, correct me if I'm wrong, but it just means that there are relevant influences from the biological, the psychological, and the social level on someone's mental experience.
Yes. So if you asked your GP or your mental health worker, they'd probably say, well, this person's depression was triggered by losing their job, or, someone close to them died, or whatever. But it's a very curious way of thinking, because actually it superficially sounds plausible. Of course, we all have minds and bodies. There must be a bio element. But there's a kind of subtle shift to assuming that the bio bit is the most important one. The most important thing is not the grief that you're suffering because someone died, or the sense of loss or confusion or lack of identity or hopelessness through losing your job, is that somehow now we deal with the bio bit that's been triggered by that, and you take these pills.
Yes.
Which is weird. And the term biopsychosocial, I think, is a very slippery one because it sounds superficially reasonable. And if you object to it, people start saying, so you're saying we don't have bodies as well as minds. But actually what it smuggles in, particularly by putting the bio first, is the idea that that's the kind of primary causal factor. That's the main thing we look at. That's what justifies calling it an illness. Whereas if we were, to say, for example, socio-psycho-bio, we might be thinking about it rather differently. Like, we live in a society where many people are very miserable, and there are psychological reasons for that. And that's partly expressed through the body, of course, because all our experiences are expressed through the body. But we don't describe all human suffering as illness.
Yes.
Human suffering is not always best understood as medical illness, and certainly the kind of things that are typically labelled as depression are not best understood as medical illness.
Okay, so are you saying that there's this sort of official dogma would be the biopsychosocial model, but that in practice there's an emphasis and a focus on treating the biology, on medicating?
I am saying in practice it's bio,
yeah,
but I'm also saying the very notion of a biopsychosocial model, as it's usually uncritically sold to people, doesn't actually stand up and doesn't make sense.
Yes. Well, I mean, my understanding is it gets criticised as just a sort of fudge.
Well, it's more than a fudge. It's actually quite a clever piece of rhetoric, I think, because it actually allows the essential medical understanding on which all services are based. And you can see that in the language people use, in the professions that are there, nurses and doctors, in the nature of the buildings, their hospitals and clinics, in the interventions, which are mostly medication. It allows the whole roadshow to carry on as before, because it slips in the bio in actually quite a clever way that it's quite difficult to challenge.
Yes, I see. We're really pulling out your interest in rhetoric and language and the power of labels and categories and words to...
Language is everything. Well, no, it's not everything, but language is important. Language is important.
Yes.
You will understand that as a philosopher, although I do see a lot of philosophers talking nonsense about mental illness without questioning the term at all, which does annoy me, I have to say. But
yes, and the term you dislike there is illness.
Is illness. I don't like mental either, but illness I particularly don't like. I like to call it human emotional suffering. You can call it a lot of things. One of the things that is important to say is that, there aren't simple replacement terms for the things we call mental illness or schizophrenia or bipolar disorder, because there aren't simple, neat packages which can be labelled as particular forms of human emotional suffering. But human emotional suffering is the territory we're in. So if you start translating some of our language uses, you go along to your doctor with a feeling full of extreme emotional suffering, and he gives you an anti-emotional suffering pill. You begin to see that it's actually not a very sensible thing to do.
Okay.
We're in the territory of Aldous Huxley here, and that's not a kind of anti-all drug statement, but it is a let's think very carefully about what we're doing statement.
I mean, okay, I guess to be clear, we should explore in what ways you think the drugs are useful sometimes to give a sort of balanced view of representation of your view.
I hate that word balanced. I'm always being told that we need a balanced view, and that always... Balanced view in very often is a piece of rhetoric for let's not present too fundamental a challenge to the status quo. And if you present too fundamental a challenge, as I'm always told I do, then you're told you're not balanced. And obviously it's a bad thing not to be balanced. Obviously, who could question the idea that it's bad to be balanced? So I sometimes feel like saying, ask me what my balanced view is about domestic violence. Ask me what my balanced perspective is on slavery. Well, maybe we should have a bit of it. Okay, I mean,
well, now, but to be fair to me, because you're giving me a hard time now.
Which
is good. But I'm giving you the opportunity to explain when you think drugs are useful. You have said, you do think they are helpful and valuable in some circumstances.
Sure.
It's not that you should never use what we call antipsychotic drugs or antidepressant.
Sure. I agree. And I'm not giving you personally a hard time. I hope I'm giving the arguments a hard time. So, I mean, I very much agree with the work of Joanna Moncrieff, who I think you know.
Yes. Okay. So Joanna Moncrieff is a psychiatrist who wrote a book called The Myth of the Chemical Cure, which is, I think, perhaps the idea you're referring to, where she's argued very strongly against the idea that these drugs that we call antidepressants or antipsychotics, the idea that they fix some underlying chemical imbalance is just wrong. There is no evidence for an underlying chemical imbalance. She will, I think, quite shockingly but quite convincingly argue with a very sort of forensic examination of the evidence, and that these drugs aren't targeted or specific in the way they operate at all. It's a bit like drinking alcohol to deal with your inhibitions, to reduce your social inhibitions. It may have that effect, but it's also going to make you bad at walking up the stairs.
You're right, yes. Alcohol is not a treatment for your social phobia.
Yes.
Nor is your social phobia caused by a lack of alcohol in the brain.
Exactly, right. That's exactly the parallel. That's
yeah,
nice,
yes. Yeah. And so what she's saying is that, psychiatric drugs have general effects that they would have on anyone, which may be experienced as a relief and a help at some points, particularly in crises, like a general sedative effect or a general stimulant effect. And if I was going through an experience of extreme crisis, I would probably want to take them for a short period. But it is about language supporting a particular understanding, which is wrong. These are not treatments for mental illnesses.
So they're useful as general sedatives or general stimulants to manage periods.
Or whatever, yeah, for some people. That's the balanced view.
That's the balanced view. There we are. We got one.
I think you'll find that many people think that's an extremist view, possibly funded by Scientologists.
Well, where did this Scientologist thing come from? I mean, perhaps this brings us on to my next question, which is to understand why your criticisms of psychiatry and why your view makes some people so angry. So I think the Scientology thing was something you were trolled. Are you accused of being a Scientologist or something?
Most people who critique psychiatric practice are accused of being Scientologists at one time or another. And Scientologists are very critical of psychiatric practice for reasons I don't quite understand, but actually I'm not a Scientologist. And even if I was, that in itself would not be a knockdown argument to show that everything I say is wrong.
The point is, why do you make people so angry?
Well, it's not just me. I mean, if you waste time on social media like I do, you will find that most people who put forward certain critiques get really quite a hard time. What you actually see is quite a lot of personal abuse and attacks of really quite an unpleasant nature. People have the right to their view, and I'm always up for a good debate. But these are not debates; these are personal attacks. So what's that about? As soon as we get into personal attacks, then clearly we are actually moving outside a rational scientific debate, aren't we? There's something else going on. And probably a lot of things. And one way of thinking about it is that there are kind of vested interests in the medical model at every level from top to bottom. It's not an accident that it's there. If you start actually looking at the critiques and how the very strong evidence that on the whole it's creating illness, not curing it, it's making people worse, not better. It's actually re-traumatizing people. Then you think, well, why are we still doing this?
I mean, but even just hearing you say that now, I feel it's a very, very powerful claim. It's a savage claim to make somehow.
It's an evidence-based claim, which of course is up for debate.
But the idea that some aspects of medicine are making us worse.
It's not medicine, though, is it?
Well,
it's not medicine. It's not a legitimate branch of medicine. That is the fundamental problem. As Peter Breggin, who's a psychiatrist himself, has said I think this puts it very well. If you actually take the critiques of diagnosis seriously, you end up saying that psychiatry is a branch of medicine that doesn't treat medical illnesses, which is a rather difficult position to be in. But actually, I think that's the position we are in. Mental health professionals obviously also have their own interests. They've built their careers on certain perspectives, and it's difficult to stand back and think, for any of us, think perhaps we got some of this wrong. I've got many things wrong in my career. It's not easy to admit. But what is psychiatry doing there in society as a whole? That's the bigger question, isn't it? And every single critique of psychiatry you read, going back to the 60s and going back further than that, in fact, is a variation on the kind of social control argument, actually, which can sound a bit kind of naive and old hippie-ish and Langian, but actually...
Okay, what do you mean, the social control argument?
The idea that psychiatry serves a purpose for society as a whole. Some people would trace that back to... historians of psychiatry would trace that back perhaps to industrialisation. The kind of rise of psychiatry happened in tandem with change to a very different way of economically organising our society, which created a lot of casualties, which then had to be swept up in some way.
So psychiatry is a form of sort of policing difficult people. Is that the idea? Yeah,
that is the idea. Kind of took off perhaps with the huge Victorian asylums where sort of all sorts of misfits, were ended up... People were seen as misfits, spending their lives. There's a very, very interesting book by Richard Warner called Recovery from Schizophrenia that argues this very convincingly, I think, that psychiatric ideology, which is what he calls it, isn't a case of kind of progress from primitive ideas we used to think then to sophisticated medical ideas we think now. It actually fluctuates with the changes in the economy, so that at times of high unemployment, where you don't need more people in the labour market, psychiatry tends to turn to more biological understandings of distress. And in essence, the casualties, the people who can't be accommodated within the labour market, are more likely to be labelled as depressed and mentally ill. And vice versa, when we need more people in the labour market, then it's very interesting to think how this happens, because it's clearly not a conscious process on anyone's part. Then psychiatric theories kind of swing back again to more psychosocial ones, and we have an emphasis on rehabilitation, and recovery rates go up.
Yeah, so is this a sort of Marxist reading of different trends in psychiatry as to what...
It is partly based on those kind of ideas, yeah. My God, that's another taboo word, along with Lang
it sure
and Marx.
Is. Here we go.
Better omit this from the edited version.
Yeah.
But, I'm sure Richard Warner wouldn't have described himself as a Marxist, but... he does actually say this fits with some Marxist ideas. So, it's really worth reading that book. It's really worth reading. So it's about psychiatry going around in cycles, more psychosocial, more biomedical, more psychosocial, more biomedical. And he does spend a little bit of time thinking, well, why is psychiatry there in the first place? And suggesting that pre-industrialisation, the things we call mental illnesses were, didn't happen, but were perhaps much less common.
So, I guess perhaps one of the points that this picks out is that the idea of a diagnosis, as we sort of currently have it, needs to be kind of fixed. It needs to present itself as an illness that would have been the same in the past and will be the same in the future.
They are. We've talked about that in the framework quite a lot. I mean, it's a big problem for diagnostic systems that expressions and experiences of distress seem very different if you look back historically, and are very different if you look cross-culturally within or beyond the UK.
Are there some sort of clear examples to just help understand?
We've given some examples in the framework, yes, but there are things like, spirit possession, for example, is one of the so-called mental illnesses that appears in a chapter called Culture-Bound Syndromes at the back of DSM-4. This is the diagnostic solution for strange things that we can't quite yet squeeze into our Western paradigm, so let's put them in this special chapter.
Right.
So it appears in there, and of course, every expression and experience of distress is culture-bound. I mean, it's a ridiculous thing to think that culture is centrally involved in expressions and experiences of distress. But from a medical point of view, of course, as you say, a broken leg is meant to look the same in kind of, the UK, in some industrialised area as it is in some rural village in India or Brazil or China or whatever. So it is that's a very challenging phenomenon.
Is something like anorexia or patterns of self-harm, are those things that we could use as examples where trends in media portrayal of certain things or reporting of certain things, if famous people have suffered with these things, it transforms the cultural landscape in a way. It makes those things, first of all, it makes people know about them where they didn't before. And in a way that makes someone more likely to enact some of those things.
So what happened to all those hysterical Victorian women with fainting fits? We don't see them anymore. What happened to Lang's catatonic schizophrenics? We don't see them anymore. We have I'm old enough to remember when anorexia was first identified. It didn't exist or virtually didn't exist as a way of expressing distress. Certainly I never met anyone who was starving themselves, when I first started practicing. So the distress is real, but different ways of showing it become culturally available. And there is, I think, a sort of social contagion. So it appears now that, many, many, many of our young people are self-harming, and without in any way wanting to dispute that they're feeling very distressed, there is an element of, well, other people seem to be doing this. This is kind of something that might be a relief to me. This is at some level an acceptable way to express what I'm feeling.
Yeah.
Anorexia is a very good example because so-called eating disorders has been quite well established, spread across the globe in tandem with kind of Western social media and ideals of thinness and all the rest of it. That is a culture-bound syndrome, very obviously. What's less obvious, I think, is that all the things we call mental illness are culture-bound syndromes in some senses.
And why is that such a problem, this cultural variation? Why is that such a problem for a diagnostic system?
Because, as you say, these are meant to be medical illnesses based in how the body works or doesn't work. We all, as the same species, share the same basic bodily functions, so you wouldn't expect a leg to get broken in a very different way in some other part of the world than it would in the UK. You wouldn't expect, you might have a lower incidence of certain diseases, of course, but, breast cancer would look the same worldwide, respond or not respond to the same kind of treatments as would pneumonia, as would malaria.
Okay, and then so before we go into the details of the framework that you've referred to many times, perhaps we should just nail down a few sort of key reasons why diagnoses, the kinds of diagnoses we're talking about, are wrong. Now, can we just, what are the kind of diagnoses that we're talking about here? Schizophrenia is one. Major depressive disorder, the sort of clinical depression, is another. What are some other ones that you think are just wrong?
This is a good question because actually if you look at some of the lists of diagnoses, DSM and ICD as they're known, they're a rag bag and they include legitimate medical conditions and neurodevelopmental conditions. So they've got lots of stuff in there. So nobody's saying that dementia is something primarily psychological, let's say. And there are conditions like, for example, autism, which covers a whole range of different experiences, some of which, I think most people would agree seem to be very likely to be basically a neurodevelopmental problem. And there are, learning disabilities of various types appear in DSM. So what we're talking about is what are sometimes called the functional psychiatric diagnoses. So there are things like at the severe ends, so-called schizophrenia, psychosis in general, bipolar disorder, personality disorder, paranoia, and at the perhaps moving a bit towards the less severe ends, so-called anorexia and bulimia and major depressive disorder and so-called anxiety disorders and so-called obsessive compulsive disorders and it's all of that territory, really. Okay,
so I mean, in a way, they make up the bulk of the kind of diagnoses that are handed out by psychiatrists, right? So I came across a wonderful quotation from Richard Benthall, who says most psychiatric diagnoses are about as scientifically meaningful as star signs.
Yeah.
My understanding, there's even a recognition by the people who write the DSM, which is the Diagnostic Bible. It's the list of all of the diagnoses and all of the criteria you need before you can apply one of those diagnoses. Even the people who collaborate to come up with that document, which is constantly being revised, agree that some of these diagnoses aren't valid. Why do they agree that they aren't valid?
That's a very interesting phenomenon, because I and other critics get into a lot of trouble for saying diagnoses aren't valid, and the very people who draw up the diagnostic Bibles are saying they're not valid. Alan Francis, who's the chair of the DSM-4 committee, has said, you just can't define mental disorders, it's bullshit. And seriously.
No, wait, so who is he?
Dr Alan Francis, sometimes described as the most powerful psychiatrist in the world, who's the chair of the DSM-4 committee, the previous edition of DSM.
I mean, he was sort of overall in charge of writing the book.
Yeah, indeed. And a lot of other very senior psychiatrists have said things like patients deserve better, the weakness is it's not valid, it's not scientifically sound. They're saying absolutely damning things about their own creation. They're not valid, and yet somehow we're not allowed to say that, and certainly service users, people who receive them, are not told that that's the case. In essence, the problem with diagnoses is that any classification system in any branch of science has to be able to demonstrate that it's both reliable and valid. Otherwise, you haven't got the basis of a body of scientific knowledge.
Okay, so reliable, just that when any psychiatrist encounters certain symptoms, they'll all come up with the same diagnosis. That's reliability,
Yes.
isn't it? That everyone...
Reliability, we can all agree that this is a case of this.
Yes,
schizophrenia,
okay.
Let's say. Reliability has to be at least reasonable.
Okay, but I guess, so the problem with reliability is everyone might agree, but everyone might be wrong.
The problem with reliability is that nobody can agree. But even if they did agree, the further problem is validity. Does this represent something in the real world? So the example I sometimes give is that in the 17th, 16th century, people reliably agreed that little old ladies living on the edge of villages with broomsticks and cats were witches. You might get the whole village reliably agreeing that this was a witch.
Okay.
Is it the case that that person was a witch, or that there is such a thing as a witch? Well, no, we don't think so now. So reliability only gets us part of the way, and the more important criterion is validity. Now, psychiatric diagnoses, interestingly, don't even attempt to demonstrate validity. They get completely stuck on the reliability problem, long way before validity. And the way you would check out validity in legitimate branches of medicine is, of course, you run a test. You say that this may be diabetes, I'm going to look at the levels of sugar in your urine, or this may be cancer, we're going to do an MRI scan and see if we can find a tumour or whatever, to put it rather simplistically. So you get out of this kind of cycle of, why do you hear voices? Because you've got schizophrenia. How do you know you've got schizophrenia? Because you hear voices. Why do you have mood swings? Because you have bipolar disorder. How do you know I have bipolar disorder? Because I have mood swings. Every diagnosis of the kind I'm criticising is that kind of pseudo-explanation. It's a circular argument. There's no exit by saying, well, we've done the blood test and it shows that, yes, it is schizophrenia. So you're, in essence, left with, it's schizophrenia because I say it is.
So what would they need to make these diagnoses valid? They would need to be able to point to some dysfunction in the brain, some disruption, some damage, something specific, biological, that would account for schizophrenia or depression or bipolar disorder. That's how if they were to make them valid, that's what you would do, right?
It's a bit more complicated than that.
Okay.
Because of course you can look at the brains of people with diagnosis of schizophrenia and see all sorts of things wrong with them, but that's almost certainly because of the drugs they've been taking.
Okay. So okay.
or there may be a kind of intermediate factor, like people with a diagnosis may perhaps eat poorly, and that may affect their physical health. So what you need to be able to do is to identify some kind of biological dysfunction, something going wrong at a biological level, and to have at least some understanding of how that links to the problems that the person's experiencing. So you need to be able to say, this is happening in your brain, and this appears to be a main causal factor that leads through these pathways, and results in you having these, what you might call symptoms. We haven't even got anywhere near doing that.
Yeah. I mean, so the reason that even the authors of the DSM agree that a lot of these conditions aren't valid diagnoses is because they haven't found those things. They haven't found a clear biological trace, or a biomarker, as they're sometimes called, of schizophrenia or depression, or any of these functional diagnoses, as you've called them. You're in agreement with them on that. I mean, I think where people go from that is often very different.
That's true. From then on, we diverge. So
Yes.
they're spending, I would say, wasting millions of dollars on trying to establish the real biological causal factors. And I'm saying, at what point do we start thinking this theory has not got us anywhere? And there's no evidence to support the existing paradigm, and there's a heap of evidence, a pile of evidence, of irrefutable evidence about psychosocial causal factors in distress. So that's where we need to be looking.
So we've introduced quite a lot of your ideas about, the ways in which you want to critique mainstream psychiatric practice. This major publication that you are the co-lead author on, but involved a whole range of collaborators, is really an attempt to put your money where your mouth is, isn't it? It's a way of trying to suggest a replacement to the way we currently do things. So can you try and explain a little bit about the power, threat, meaning framework, what you were trying to do with the publication, and the kind of the basic ideas of how it works?
Well, you summarised it pretty well, actually.
Oh, thank you.
Maybe we can leave it at that, 'cause it's a long, complicated document. In essence, this is the end result of a 5-year project that, as you say, I and Professor Mary Boyle were co-lead authors on. But that is the purpose. If the medical model understanding doesn't work, what is an understanding that would look different? And of course, there are already a number of ways of working non-diagnostically or beyond diagnosis within and outside services. So the message is not replace those. It's a kind of, we're calling it a meta framework. The idea is to provide a really solid foundation for a lot of the non-diagnostic work that already exists, and also suggest other ways forward. And a really central part of that is to be able to say, instead of the patterns that diagnosis claims to identify in mental health, we need to find another way of identifying patterns in distress, a non-medical way. What would those patterns look like? How might we describe them? How might they better serve the aims that diagnosis is said to serve and actually does very poorly in psychiatry? Things like identifying causal factors and ways forward, and performing all the other functions the psychiatric diagnosis also serves in many areas of our life: access to welfare and benefits and commissioning services, and as a basis for research and so on.
So can we start with the elements in the title? It's called the Power, Threat, Meaning Framework. Why is it called that?
It's a long and complex document, as I've said, and we wanted some simple ideas to hang it on, if you like. And there's a very common survivor slogan, which goes, instead of asking what's wrong with me, ask what's happened to me. So we've kind of taken that and expanded that, because that seems to express the essence of a lot of what we're trying to say. So we've developed these 4 questions, which of course are not meant to be taken absolutely literally, but are meant to indicate the areas you need to explore in the case of any particular person's experience of distress. So the first question is, what has happened to you? And in PTM terms, we've called that how has power operated in your life? We've placed a very great deal of emphasis on the role of power in the power, threat, meaning framework, because it seems to us that that's what most commonly gets omitted, not just from medical understandings, but very often from psychotherapeutic and psychological understandings.
So the first question, what has happened to you, or how has power operated in your life?
That's right. Second question, how did it affect you? And in PTM terms, that translates to what kind of threats does this pose? And you can't really discuss power without discussing threat. And so as we go through the questions, you'll see they're not clearly distinguished from each other. These are not kind of 4 different aspects of our experience. These are aspects of our experience that arise out of each other. The question after that is, what sense did you make of it? Or in other words, what is the meaning of these situations? So there we have power, threat, and meaning. And we've considered meaning in a kind of quite a broad, complex sense that we think takes us beyond the common sense in which many therapies look at meaning, but tend to sort of stop the search when looking at more personal individual meanings, and tend not to take the search further towards social discourses and ideological meanings.
Okay, that's interesting. So you would position this the PTM framework is critical, obviously, of the biomedical model, which we've discussed a lot, but also of other sort of therapeutic techniques.
You're right. Yes, I mean, one of the things we discovered fairly quickly when we started unpicking diagnosis was that it's not just about diagnosis as such. It's about a kind of diagnosis is an example of a whole tradition of thinking, which, I mean, you will know about this from your studies, which philosophically its roots go back many, many years. It's connected with often dominant Western ways of prizing, particular ways of thinking, more rational approaches, perhaps going back to the Enlightenment, going back to the Greeks. So and a lot of that, what we're critiquing is not diagnosis as such, but individualised or narrow ways of thinking, which can also underpin a lot of psychotherapeutic approaches. So actually, we're just as critical of narrow versions of psychology as we are of psychiatry.
Okay, well, I mean, what kind of psychotherapeutic approaches are we talking about? Like psychoanalysis or CBT or...
Well, any. I mean, there's no therapeutic approach which is absolutely incompatible with the framework, I don't think, if it's carried out sensitively. But CBT in some versions is carried out in a very narrow, individualising, tweak the negative thoughts in your head way, which is just as bad in a way as saying tweak the biochemistry in your head. It's another version of the same thing. The problem lies within you being, in some senses, a dysfunctional individual, rather than you doing your very best to survive in a difficult world. The fourth question is, what did you have to do to survive? And we're translating that as what kinds of threat response are you using? So a threat response roughly corresponds to the thing that might often be called a symptom in psychiatric terms. Sort of mood swings or panic or anxiety or hearing voices or having unusual beliefs. Although we've also said that a lot of things that are socially valued can, for some people, in some circumstances, be understood as threat responses, like kind of working much too hard or being ruthless with the people you're managing at work or whatever. So instead of symptoms, these are ways in which people, at varying levels of consciousness and control, try to survive the difficult circumstances they find themselves in. If you were sitting down one-to-one and working through these questions with them, then you would almost certainly want to add or perhaps start with what are your strengths, or perhaps what power resources do you have access to. And the end of this process would be something like, well, what is your story? How do we put this together? And we mean story in a very, very broad sense. So that might include all sorts of things that aren't traditionally, written or verbal stories. Many people find poetry, art, music, community rituals, cross-culturally. There are many ways of putting together and making meaning out of people's stories.
So you explained to me earlier the idea of formulation as a process that many clinical psychologists use now, which is building a story with an individual about their experience that has led them to this point. To what extent is this different from that?
That's a good question. We have deliberately used the word narrative instead of formulation. So narrative is any means that's helpful and to you or to your family or social group, perhaps, in making sense of your experience. Formulation is a particular kind of narrative creation, which has some particular advantages. I think in services it's kind of accepted as a way forward. It has a certain amount of evidence to support it. But we really didn't want to make this a document about psychologists promoting their formulation skills, and we wanted to make it very widely relevant and accessible, and that means opening it up to the widest possible form of narrative, which allows us to look, I think, rather differently than diagnostic models at many healing rituals, for example, cross-culturally, across the globe, which can be understood as forms of narrative. Although you wouldn't specifically call them formulations, but they clearly have a very important role in healing distress in many places.
Okay, so is it fair to say it's a sort of broadening out of a formulation approach?
I think we'd rather see it as approaching at the other end. It's a discussion about narrative, which has some implications for formulation, which is a culturally specific, co-constructed form of narrative, but it's not universal. And one of our messages is this doesn't have to be just about professional skills. You know, psychologists make a big deal about formulation and how many years they have to train to do it. But actually, we want to make this the framework as a tool available to anybody who doesn't have to wait on a psychologist waiting list for a year to get their formulation work. And we've been encouraged to find that some peer support groups have taken it up and have used these guiding questions to put together their own stories with no input from professionals whatsoever. So that's really very encouraging to hear.
Okay. So we've got these four central questions, and we've got this idea of how has power operated in your life, and how have you responded. Right, that's the core of it. Where does it go from there? What's so sort of novel and different about this a whole framework, which is, and this document is a long and complex document. It's like over 400 pages long, right? What next?
So what's new about it? Well, one of the things we've tried to do that is new is to identify the general patterns that could support personal or group narrative making. So the appropriate form of pattern identification for human emotional suffering rather than things that go wrong with our bodies.
Okay, so you've said before that in a sense the diagnoses, which you're rejecting, identify patterns. You're also seeking to identify patterns. So why are your patterns different from diagnoses?
So medical diagnosis works pretty well when things are going wrong with our bodies. And it works quite well because it is a form of identifying patterns. When this happens at this level in your body, and then it affects your liver or a pancreas in this way, and then you experience these symptoms. So we set ourselves the task of finding a form of pattern that is appropriate to human emotional distress and that acknowledges the fact that as human beings we make meaning out of our experiences. If I can put it as briefly as I can, the kinds of patterns you need to identify are very, very different. And the conceptual leap that we eventually got to was to argue that instead of patterns in biology, which is essentially what's happening in medicine, we are looking at patterns of meaning, or rather patterns organised by meaning, because as we've just said, that involves our bodies, everything involves our bodies, but the organising principle is meaning.
Okay, so we need to understand what you mean by patterns in meaning or patterns of meaning.
Okay, so what we've provisionally done, and I think this is the bit of the document that probably needs most development, but we hope we've identified some principles, if you like, is identify common patterns of meaning that cut across diagnoses and that are not and can never be of the kind of neat cause-effect patterns that we hope to find in things that go wrong in our bodies. We need to get our heads around the fact that anything based on meaning is necessarily has an on average character. It will be filtered by personal experience, by personal meanings. But if you take all that on board, it is still possible, we think, to identify broad patterns which express particular forms of distress arising typically within particular sets of circumstances and expressed typically through particular threat responses. But none of those things are absolute. The patterns overlap with each other. Let me give you an example to see if it works. Okay, so one of the patterns we've identified very provisionally is called surviving separation and identity confusion. So you can immediately see that's about meaning. You know, who am I and how can I separate from my family and find my own way in the world, perhaps? And it's about something people do, surviving, not something people have. You know, I have bipolar disorder. And it's a very loose pattern. It could apply to many of us in very different circumstances. But over many years, I've worked with a lot of people aged about 18 to mid-20s who have received diagnoses of things like psychosis or eating disorders or sometimes OCD, and yet it seemed to me that many, not all of them, were struggling with a common dilemma about how can I separate from my family of origin? Who am I? What are my values? What's my life going to be like? How can I move out into the world and make a life for myself? They're, tasks which are difficult for all of us and particularly difficult for some people for all sorts of reasons. So rather than understanding those as separate cases of psychosis and eating disorders and so on, a lot of those people could perhaps be understood as struggling with a core meaning-based task of separating from their families and working out who they are. Who am I? What is my identity?
So what you're doing is you're identifying a certain pattern of experience in people's lives that has a certain kind of meaning or certain kinds of meaningful challenges to them, that then presumably there are certain kinds of responses that people tend to come up with.
That's true. I mean, each of the patterns we've provisionally identified has a characteristic set of power, threat, meaning and threat responses aspects. So the existence of these patterns, they're like kind of a formulation is a one-to-one thing. This is like a meta-formulation or a meta-narrative, if you like.
But can you just give us some examples of that pattern you talked about? So leaving home, finding out who you are, moving away from your family, how are you now going to live your life? What are your values going to be? What's your identity going to be? What are some of the ways that people sometimes respond to that that's made it into your pattern that can become very severe and cause distress?
Well, I think I'm saying that at least some of the things that are commonly diagnosed as, let's say, eating disorders or psychosis can be understood in that way, and not all of them. Not all of them, but some of them, and each will have an individual flavour. So for some people, starving yourself may be a way of kind of a sort of false solution to a very difficult dilemma. I don't have to move on in the world. I don't have to think about these scary things. I have a reason for getting a bit stuck at this stage in my life because, I'm channeling my anxieties into my struggles with food. And of course, each of these patterns is very much rooted in particular cultural understandings or available ways of expressing distress. So in a different culture, you might express that differently. But a lot of people struggle with food nowadays in Western cultures. So there's a cultural aspect to all of these experiences. And, you'd find very different ways of expressing that dilemma in different cultures, but then in different cultures you might find a very different set of circumstances where, for example, in an extended family culture, this dilemma wouldn't appear in that kind of way or might be much less acute. It wouldn't be the same expectation.
Are these kinds of patterns, are they coming out of evidence?
Well, we are saying they're coming out of evidence. Yeah, I mean, you'd have to read the evidence to see if you think it's convincing. We are saying these are evidence-based patterns. A lot of the evidence is framed in very traditional terms. If you look at it through a PTM lens, we are saying these are evidence-based patterns. So they not only support the idea that narratives themselves can be evidence-based, they can support the construction of particular narratives. So if you're sitting down with someone and trying to construct a narrative, it might be helpful to say, well, if we look at this broad pattern, does this throw any light on your struggles? Are the things that are relevant to you? Does this perhaps help to convey some of the more helpful messages that people report from diagnosis, like, oh, it's not just me, or oh, other people feel the same, or oh, I don't have to blame myself or feel guilty myself.
Okay, so it could actually serve the function that diagnosis sometimes serves, which is to make people feel relieved that they're not alone, that there's something that is recognisable about what they're going through.
It could do, the kind of commonality bit. It's understandable, it's not just me. I can see that I'm doing the best I can in difficult circumstances.
Yes, okay.
I mean, I guess one other thing to say that we're really trying very hard to do in these patterns and in the project in general, which relates to the power aspect, is restore the links between personal distress and social injustice. That's where the power comes in. That's the bit that diagnosis is particularly kind of damagingly excluding of. So as soon as we start thinking we've got an epidemic of depression, we stop looking, or to some extent we stop looking at the reasons why so many people are so miserable in their lives.
Let's talk about this question of power and social justice. So the idea of power is fundamental to the framework. Where does it come from, this idea? Are there sort of major theoretical roots that it has? To me, Foucault is associated with as a theorist who thought about power. Is that the sort of place where it's coming from?
Yeah, partly. Yes, we've got a long chapter on philosophical principles, and Foucault appears quite a lot.
Okay, yeah.
So that's a very convincing and useful power analysis, I think. I mean, a lot of it comes from the evidence. We have an overwhelming amount of evidence of the importance of the impact of power on people's lives and on their later experiences of distress. And that includes misuse of interpersonal power, abuse, trauma, bullying, domestic violence, and so on. It also includes what could be called more, different forms of being on the negative end of the operation of power, losing your job, living in poverty, having very few opportunities. It includes more subtle things like lack of access to social cultural capital, like belonging to a group that is sort of stereotyped or denigrated. Most importantly, from our point of view, it includes ideological power, which we're defining as power over people's meanings and values and agendas. So the imposition of meanings on people's lives is not something we often think about, and yet imposing a diagnostic understanding on someone's distress, the start of the process of turning people with problems into patients with illnesses, is an immensely powerful thing to do, all the more powerful because it's presented as a kind of expert, professional scientific fact. But actually, it's an act of extreme injustice, as we would see it, and it's an act which cuts you off from your own understandings of your distress. At a broader sense, it severs the link that we all need to be clear about between personal distress and social injustice, and it can start people too often on a lifelong journey of being a psychiatric patient, and very few people are offered alternatives. And we want the framework to be one alternative. You do not have to understand your distress in this way. There are different ways available.
So understanding how power is operated in your own life is part of this approach.
It's key, yeah.
But you're also rejecting the power of the psychiatric institution to impose diagnoses and categories on your experience.
We're kind of calling them out, if you like, and saying, in your own terms, this is not scientifically valid. These are not legitimate medical categories. But we're also saying, what is this about? What is this about? If it's not about, I'm sure this is what a lot of people think they're doing, telling people some kind of medical truth. But if it's not about that, what is it about? It is very often about silencing people, about concealing very difficult stories about abuse and trauma and all the rest of it, not looking at the kind of society we live in, which leads an increasing number of people to experience distress. Supposedly 1 in 4, we seem to be heading towards 4 in 4, and I do wonder at what point we start to turn from the focus on this epidemic of so-called mental health problems to think, what kind of society are we living in that so many people appear to experience as extremely distressing?
But if you're rejecting what you see as an oppressive ideological power of the psychiatric institution to impose meaning, in order for this to be consistent, this approach, do you need to disempower yourselves? You're no longer an expert that knows how to help people in some sense, or do you need to be consistent, remove some of your own power?
Yeah. We have to look very honestly about our own power too. We as psychologists, we as professionals, I'm a psychologist. I have a number of forms of privilege. I've been lucky in my life in many ways. Of course, I have forms of power. And I think I want to say that not all power is negative. And I hope that at least some of the time I know this is true of my colleagues, have been able to use power positively. So it's not about there is no room at all for professionals, but it is about being very honest about our own use of power. That's true. And it is about trying to, give power away, if you like, or make other forms of power available to people, particularly different ways of making meaning of their distress.
I think that the topic of power makes it clear the extent to which this is quite a political framework.
I think it is explicitly political, actually, with a small p. We need to put the politics back in mental health.
Okay, so in what ways do you think it's political?
It's inevitably political because it's making the link between distress and social injustice. What kind of society do we live in? Who organises it like that? What kind of power, resources do people have access to? Who are the winners? Who are the losers? What are the end results of that? And how do we deal with the suffering that people experience when they're, at the bottom of the pile, if you like?
Is that a problem for the framework? You can't roll out a national service of support for mental health which has a strongly, probably kind of left-wing political agenda, could you?
Well, interestingly, in some quarters we've been identified as right-wing, supporting a neoliberal agenda, because we're not stereotypically saying everyone's a victim of capitalism and they can't help it. We are balancing that kind of stereotypical view with a strong emphasis on the fact that human beings have agency and make meaning and can make, within certain constraints, choices in their lives. So I hope it's not straightforwardly and obviously playing to either a left-wing or a right-wing agenda, but probably you're right, it's kind of more left-wing than right-wing if we want to think of it in those terms. But I do want to say this is not about ruling anything out. We've been very clear that this is a set of ideas, this is a set of conceptual resources, and if people want to use it, that's fine. If people want to ignore it, that's fine. If people want to disagree with every word of it, that's fine. It's not up. We wanted to publish it and then really, really say, well, over to you folks. Maybe it'll sink like a stone and no one will ever do anything with it, or maybe it'll take off, and actually it's taken off already beyond our wildest dreams, which is great.
My last question is, how are you looking to develop it? What are you working on now? How do you move forward with this?
We as a project team are available to support people who are interested. Really, really, it's about, if this is going to go anywhere, it has to be because other people take it on. There's only kind of 9 of us. We can't do it all ourselves. And, collectively, we've done about 100 events since the launch, which is only 9 months ago. There's already a Spanish version. There's going to be an Italian version. There looks like there's going to be a Danish version. I'm doing a small tour of New Zealand and Australia with one of the other project authors. I've been all over the country, and other project team members have also been doing events. So there's a huge amount of interest. So that's what we're going to do, really. I don't know how much you believe in the kind of paradigm shift stuff, and we are not claiming we have produced a paradigm shift. But if you read that stuff, then about how do we make major shifts of understanding in a particular field from one worldview to another, then the process becomes kind of self-perpetuating at some point. And it seems to me that the medical paradigm of mental distress is crumbling at the roots. It cannot survive any longer. These horrendous findings, how damaging its interventions are, how little support there is for its basic assumptions. Something different will happen. I don't know what it's going to look like. If we made a very small contribution to it, that would be fantastic. But I think that's the era we're in, and I hope to live long enough to see what the next step's going to be.
Dr. Lucy Johnstone, thank you so much for speaking with me.
Thank you.